All right, so the idea for this morning really was to start with our first couple of talks really at 50,000 foot level and set the stage for where we're going in healthcare. And I'm going to now come down to, say, the 10,000 foot level and really try to tell a story of our story, Hoag Orthopedic Institute, on how we got to where we are today and how it fits into this whole day in terms of value-driven care. And then following that, Caleb and his team are going to come up, and we're really hoping that we can engage the audience in helping to drive change in healthcare. So who is this guy, and why is he smiling? This is Ezekiel Emanuel, and for those of you who don't know, Zeke was one of the key authors of the Affordable Care Act. Even though Zeke is an MD, he doesn't really love MDs. In fact, he doesn't trust MDs. He feels that because of all of the things that David was talking about in terms of supply-driven demand, that inevitably doctors are going to do the wrong thing. And so Zeke was more than happy to use the suggested legislation from the American Hospital Association and weave that into the Affordable Care Act to prevent physicians from owning hospitals. And so what David talked about was the fact that when you've got large institutional players that are resistant to change and want to maintain the status quo, they start putting up barriers to change. And one of the barriers was to avoid the competition of physician-owned hospitals. And so when Dave dragged Zeke kicking and screaming to Hoag Orthopedic Institute to sit down with us and to talk to us, it was an interesting day for all of us. And that's because his expectation, as you can see here, and by the way, the advisory board, this is sort of the Wall Street Journal for healthcare for hospitals that comes out. And so he wrote an article for them saying, I expected to come to this hospital and just see the worst of the worst, greedy doctors doing the wrong thing. But I didn't. And in fact, I saw the opposite. And he wrote, to his credit, he wrote that. And he wrote that to a very large audience. And so how is it possible that Zeke Emanuel would come into this building kicking and screaming and then leave and become one of our biggest advocates? How did that happen? So let's talk about that briefly. And the theme for all of my talk today is the concept of alignment. And I believe that in order for us to move forward and to get to the type of status quo that Dave just talked about, we have to do this in an aligned fashion between the physicians and the healthcare systems themselves, and really have the same goals if we're going to do this. And so our first step, our putting the toe in the water for alignment, occurred in 1998. And the reason that occurred was because we came to the realization back then, as practicing community-based physicians, that change was coming. And the reason that we saw change coming was because of the massive influx of what were called HMOs, or health maintenance organizations, and how that was really starting to affect the payment model in our world in Southern California. If we extrapolated from that and we started to realize that over time, the dollars were going to become more scarce, not just for the physicians, but also for the hospitals, then we could move to a model that would really need to drive efficiency. And if we're going to truly be efficient, we have to get rid of the fight that's going on typically between doctors and hospital administrators. And that means we need to be partners. And so we marched into Hoag's administrative offices and asked them to partner with us on a surgery center. And at that time, remember, you have to think about, this was 20 years ago, at that time, Hoag had never done a joint venture with doctors. And so that was a foreign concept, and it took several discussions before we were successful. But we did it. And so why were we thinking that way? I really feel that we had a head start in this whole concept in great part because we are in California and because Kaiser is a dominant force in our market. And for those of you who are really not familiar with the Kaiser model, This was really the first integrated delivery system model that occurred in the United States, and it started in World War II. Henry Kaiser put together an organization where they were the payer, they were the insurance company essentially. They owned the clinics, they owned the facilities that would take care of all of their employees and their families, and they employed the physicians. So they owned all of the pieces in this care delivery model, and through that, they created an aligned system, the first aligned system of care delivery, and they were based in California. And what the insurance companies in California saw back in the 80s and 90s was a competitor that was very formidable, that they really couldn't compete with as not-for-profit insurance companies. And so through their lobbyists and others, they started to work on legislation, and they changed legislation at both the federal and state level to allow them to become for-profit enterprises and to start to introduce new types of insurance models like capitation, which was a whole different type of model for payment for physicians. As you can imagine, as a young physician in private practice in Orange County, this was a difficult time to be in private practice because your whole way of being paid was starting to change pretty dramatically. And for many of the physicians, they resisted this change, and they unfortunately had a very difficult time moving forward. But for some of us, we saw this as inevitable, and we embraced this change. And I kept saying when I was giving talks back then, don't worry, you guys on the East Coast, this is coming your way. Well, it never did, and it still hasn't. And in fact, we still have double the rate of penetration of managed care in California to the rest of the United States. And I'm going to touch on that further because it's even propagated now in the CJR model that's gone forward with CMS. So we needed to develop a model that we could not only survive with, but potentially thrive with if the world changed. And one of the things we needed to incorporate, in my opinion, was not just the economic model, but the human part of this model. And these are two authors that I would encourage you to look at. Richard Zuckhauser at Harvard and Daniel Pink has written a great book called Drive. One is a behavioral economist and one is a sociologist. And if you take the basic elements of their books and you bring them together and incorporate that into the model of alignment, you are going to not only address the human needs on the hospital side and on the physician side, but you're actually going to have a more sustainable model if you think about the human dynamics. And one of the greatest challenges is, you can imagine going to Hoag and saying, do you mind if we take your largest service line and take it out of the hospital and move it to a different location and own half of it? Is that okay? That was a long, iterative discussion. And yet, I will give Hoag huge credit because it was their board and it was their administration that took that gamble and took that risk, despite the fact that when you look at human dynamics, people fear loss 4 times more than gain, if you look at all behavioral economic studies that have been done. And so on both sides, both on the physician side and on the hospital side, both sides are fearing loss of their revenue, they're fearing loss of control, they're fearing change, they're fearing the future. Remember, this is before Michael Porter wrote Redefining Healthcare. And so Hoag was very prescient in making this decision and working with us and moving forward. And the goal and the game plan was, we are going to align every aspect of care delivery. And if we do that and we actually measure it, so that, Peter Drucker is famously being quoted as, you cannot improve what you don't measure. And so we were driven to measure our outcomes and our costs and our patient experience through this whole process, and to do it in a transparent way, both transparent internally and transparent externally. And if we did that and we truly succeeded, we would deliver value. And so we believe that the greatest opportunity for hospitals and physicians moving forward is to really come together in a frictionless model. you've got deep knowledge on the hospital administration side that physicians really, they think they know, but they really don't. And then you have deep clinical knowledge on the physician side. Why not use both in some sort of an environment where it is not filled with friction? And so that was really our model, and that's what we all came together on starting in 2006 and 7. And we actually were fortunate that we had leaders like Robert Braithwaite, who's sitting here today, who went marching into Washington, D.C. With me when the Affordable Care Act tried to exclude physician ownership. And we were very fortunate that we were able to influence a small change in that act in order to build Hoag Orthopedic Institute. So we also embraced the concept that it's not just the hospital administrators and not just the physicians, it's every single member of the care team that is going to drive value. It's the nurses, it's the medical assistants, it's the physical therapists, it's the pharmacists. Those who are closest to delivering care actually are the ones who have the greatest opportunity to drive value. And so we have an amazing performance improvement committee that our Chief Medical Officer, Bob Goreb, controls every month and brings forward this integrated group that talks every month and goes through the data every month to try to drive value. We're growing. Gradually, we're growing in terms of our volume. Since inception, we started and actually opened our doors in late 2010. And we measure everything, as you can imagine. We measure all different sorts of things in terms of readmission rates and surgical infection and outcome scores for hips and for knees and for spines. And we also measure what it is in terms of patient experience. And we benchmark ourselves across the state, across the county, across the federal government, because we believe in pushing every single time we get together. The other thing that we believe in is learning from others, and that's part of the reason that we're here today. Is we've got some fantastic people from around the United States and Europe to help teach us how we can get better. And so we made a point of learning from others and joining other learning communities throughout this journey in an effort to try to improve and to continue to improve. We also learned about something that Amy touched on earlier, which is time-driven activity-based costing, TDABC. This was actually developed by Bob Kaplan at Harvard Business School. And this is a very granular exercise where we had people with clipboards and stopwatches following us around our offices, following us through the hospital and into the operating room. And not just the physicians and surgeons, but also our nurses and everyone else, so that we could actually calculate down to the minute what the cost was for every aspect of care delivery. That's pretty granular. But that actually starts to give you some insights. We then can map this process, and we start looking at care cycles, and then we start to get some insights. And we start to realize that it really does matter in terms of the total cost of care where the patient goes after they leave the hospital. Whether they go home or whether they go to an acute rehab facility has a dramatic impact on the total cost of care. And unless you go through this exercise, you don't have that moment where you say, oh my goodness, maybe we should be sending them home. And now we do. And then we went to the next level and we started giving ourselves report cards, because as physicians, we're used to being tested and graded all day long for our entire life. And so why not give ourselves report cards? But we also give the hospital a report card, and we go through this report card at our performance improvement committee on a very frequent basis, on a quarterly basis. And so we look at things like all of those metrics that I collected, but then the physicians get a report card too, and they are benchmarked against the other physicians in the hospital. So this is what helps to drive change, is that illumination that Amy talked about earlier in terms of the data, looking at your own data and how you compare to others and how you can learn from others, and not just outcome data. We look at things like, did you open up an implant and not use it? Because if you did, that's wasted cost. And you need to know how you're doing in terms of wasting cost and your total cost compared to others. And just giving people information helps to create that level of change. We don't use information as a weapon. We use it as a learning opportunity. And we publish it. Good or bad, we're committed to publishing our outcomes on an annual basis so that we're transparent externally and we're transparent internally. So we've been running along now, and how are we doing? Well, we were very fortunate in that when the first year that CMS came out with their rating system, we were the only 5-star rated hospital in Orange County. We were fortunate in that Bob Kaplan brought his team out and did a case study in 2015 on HOI as a value-based institution, and we've been fortunate to go back and help to teach this class at Harvard Business School. So we looked at all of the data, and we felt after 5 years in looking at how we were doing that we had achieved our goal and we had started to drive value. But I think more importantly than all of that, we had actually achieved the goal that we set out, which was to create the level of trust between the different players and alignment between the different players that reduced the friction. Because really, at the end of the day, it's people. The hardest part of this whole enterprise is the human part of the enterprise. And so if we can create alignment and trust between all the different constituents that deliver the care, that's the secret sauce. That's what's going to drive us forward. When it comes to bundled payment, we were early in bundled payment. In fact, in 2007, our executive director of our surgery center brought to our attention the fact that patients are going all over the world seeking relatively straightforward procedures because there's less cost. They can get the same outcome in the Philippines for less cost, a fraction of the cost as they get in the United States. And I'm sure you've all heard about travel medicine. And so we asked the question, well, why can't we do that? Why can't we do that by delivering procedures that are traditionally done in a hospital in our surgery center? Something like a hip replacement, which in 2007, no one was doing hip replacements in a surgery center. And so we asked the question, could we do that? And could we do it safely? And could we deliver the same outcome for a significantly lower cost? And then if we did that, would we attract another class of patients to our institution? And so we put the program together to start doing simple spine cases, hip replacements, and things like that in our ambulatory surgery center. And it worked. Now, I have to tell you that when I gave a lecture at the American Academy of Orthopedic Surgeons in 2009 on our first 100 cases at our surgery center, 2 members of the audience stood up and told me this was malpractice, that we were doing this, that we were sending patients home in less than 4 days was malpractice. I will tell you also that currently the average length of stay for our entire hospital, whether it's for spine cases or total joints, is less than 2 days now, is 1.7 days. Kim, is that right? Okay. So we started this program, and essentially what we were doing was we were saying to employers back in 2007, 2008, we will do a hip replacement for this much, all in. Facility fee, surgeon, anesthesia, physical therapy, all in, here's the number. That was a bundle. We didn't really call it a bundle back then, but that was a bundled payment. By 2010, people were really starting to look at this concept, and we were asked by the IHA to start looking at doing a pilot program in California on bundled payment, which we participated in. And we actually, HOI became the largest provider of data to this program. We then joined with Jens and ICHOM, and you're going to hear from Jens later this afternoon, in terms of starting to systematically look at outcomes and outcome data that we could collect and standardize internationally. We joined with Harvard, as I mentioned, and all of this was in preparation for what we believed would be the coming of bundled payment. And sure enough, in 2016, the federal government said, we're going to pay hip replacements in your part of the world through a bundle. and knee replacements as well. And why are they saying this? Because they've looked at all different kinds of payment models, and they finally settled on one that actually helps to lower costs, make the costs predictable, and cause institutions to constantly try to improve and deliver that margin in a different way, as we talked about earlier. We went one step beyond that. The same executive director said, why don't we put this on our website? Let's put our costs on our website. We'll put our global cash payment on our website. Let's shake it up a little bit. And we did. But despite all that, we're still being punished because we're on the West Coast. If you look at the 9 regions of the United States and how they are paid by the federal government for primary hip and knee replacement, we are paid the least on the West Coast. I'm not sure which legislator got in their ear to set up this payment model rather than creating a single price across the United States and driving change through a single price. But that's okay. We've been here since the late 80s, and we can do this. And I believe that if markets rule, gradually the market's going to realize that this should be a standardized model across the United States. And in fact, if you look at the reconciliation after the first year, the federal government would reconcile whether you were over or under the predicted cost, and then would either take money away or give you more money. We were number 3 in the United States, but had everyone been paid the same, it just happens that these 2 are in the highest payment area of the United States. Had we all been paid the same, we would have been number 1. So our goal is to deliver value, to eliminate friction, to move towards alignment. That's really our goal. And our hope is that HOI acts as a change agent in this regard. But the question now is, okay, we've done bundles, we've done this, where are we going? And I'm just going to give you a little piece of this, and Jennifer is going to talk about this a little bit more later this morning. But we believe that the next thing we need to really focus on is beyond the individual procedures and instead move into the disease state. And you're going to hear about this from Jens today, but we need to focus on the management of musculoskeletal disease from one end to the other. We believe that there are changes being made, and Dave talked about what is going on with AZAR and others in the federal government now that are starting to send these warning shots across the bow that we are going to be shaking up the status quo. One of those warning shots was that CMS ended this differential payment program between hospitals and outpatient surgery centers. And so finally, we're moving towards a level playing ground. And that's a tipping point. They're still trying hard to keep doctors in their place, but I believe that's the wrong way to move. Instead, what we should be moving towards is alignment, because if you actually look at the top 100 CMS-rated hospitals in the United States, 31 of them are physician-owned. None of them, except for HOI, is owned in a joint venture fashion between a community not-for-profit hospital and the physicians. And I believe that's a model that wins for everybody. So we're moving since 1998 down this road. We're still on this journey. There is no finish line. I wanted to give Dave a plug because I think that what he talked about in his blog in terms of how the world is changing is something that everybody in this audience really ought to embrace. We ought to embrace this change, not resist this change, and put models together that will thrive. So thank you very much. I want to now turn it over to Caleb and his team for the next step. And we're going to continue to sort of move from 50,000 feet to 10,000 and farther down until we have all of these problems solved by the end of the day. Thank you.